All right, so today class will be starting chapter 14, which begins on page 311. So based on our conversations, I see that you understand things better with analogies. So to sum up what an MI is and what's going on, picture yourself in a car on your way to school. Everything's going smooth, music's going, it's nice flow of traffic, you're making all the green lights. Um, and then just out of nowhere, you see traffic starting to slow up. As you coast along, you notice that there has been an accident. So the accident is an MI. The road you're traveling on would be the coronary arteries. The lane that you're driving in would be the blood vessels in the artery, and your car is the red blood cells. You having to change the directions to go around the accident itself. Um, Mirrors the changes that you will see on the EKG itself. Keep that in mind as we go through this chapter. All right, MIs affect the different layers, affect the different layers of the heart. How many layers of the heart do we have? So if you know, I would like for you to drop your answers in the comment section down below. Okay. Um, if you're having trouble remembering, refer back to chapter 1. Miss McGee, again, I know all this is a foreign language to you. You may know this, you may not know, but just for your benefit, we have 3. Okay. Um, you see that myocardial infarctions involve death of myocardial tissue, area deprived of blood flow by an occlusion of a coronary artery. Process begins with ischemia and injury. Okay. So why is damage to this part of the heart bad? Um, all right. So we see that there are 2 types of MIs: ST elevation MI, which is a STEMI, tend to be transmural, usually involves the full thickness of the myocardium, results in ST elevation, ST inversion, significant Q waves, usual symptoms of an MI. Right? You have 2 types of MI. You have the non-ST elevation MI, which is the NSTEMI, tends to be subendocardial or incomplete, usually on partial thickness through the myocardium, damaging innermost layer of the myocardium just beneath the endocardium, can be difficult to diagnose. Okay, and why can this be difficult to diagnose? I want you to be mindful. Let's just keep that question in mind. Be mindful of that as we continue to go through this. All right. Um, Puts us here. See, figure 14.1 shows you what the affected areas look like. You see the STEMI that relates to the endocardium and the myocardium. You see that damage is being done, and you see the what it looks like with the end-STEMI. All right. So have the symptoms of the MI: classic symptoms and chest pain, left-sided chest tightness, heaviness, pressure. Can extend from the chest to jaw, neck, back, down the arm. Neuropathy can diminish pain sensation. Women's angina equivalent, post-menopausal women, fatigue, shortness of breath, or other vague symptoms. And I remember that I used the analogy I shared with you all that episode of Grey's Anatomy when Miranda thought that she was having a heart attack. Okay, all right. And just to further elaborate on that, the pink areas are areas in which you would experience discomfort during a heart attack. All right. These are some common areas where women will feel discomfort. Some of the symptoms that women will exhibit during a heart attack. All right. So the symptoms of an MI. All right. Again, shortness of breath, nausea, vomiting. They'll tend to be paler. diaphoresis, arrhythmias. Not all patients with MI have the same symptoms. Okay. All right. The three eyes of infarctions. It's a sequence of events that occur when a coronary artery becomes occluded. Again, so thinking back, keep in mind with the traffic accident. Right. Ischemia. T wave inverts. Tissues starving for blood and oxygen. Myocardial tissue is pale and whitish in color. Right. So when I'm looking at the EKG and I see that the T wave is inverted, immediately I'm going to think about it being ischemia, and I'm going to begin checking other leads for other criteria just to verify that what it is that I see. Right. So now we move on to injury. Tissue being injured by lack of perfusion. Tissue is bluish in color, noted by ST segment elevation on the EKG. Again, when I see ST elevation, I'm going to immediately start the check down process. Right? Infarction, myocardial tissue necrosis turns black, noted by significant Q waves on the EKG. Dead tissue will become scar tissue. Again, start beginning with the check down process. Right? 14.3 shows you the different areas that we just talked about, for the ischemia, injury, and infarction, and what they look like on the EKG itself. You see the ST elevation, you see the inverted T wave. Oh, my bad. Oh, it won't let me go back. So I'll come back to that. We have the ST segment, concave U-shaped ST segment associated with pericarditis, but also seen with the STEMI. Abnormal can be elevated or depressed. ST depression, ST below baseline, and we talked about how everything begins and stops with the baseline. So anytime anything is coming off the baseline, then we know we have a problem. Okay, implies ischemia or reciprocal changes opposite of area of infarct. All right, so that puts us on 14.4. You see this gives you a better idea of what to look for. We see that what a normal ST segment looks like. We see what a concave ST elevation looks like. We see what ST depression looks like. We see what convex ST elevation looks like. All right, the T wave, normal, is rounded with amplitude, or would be less than 5 millimeters, and frontal leads. All abnormal T's can imply ischemia. And again, that's what I said in the beginning. When I see that, I know it immediately. I'm going to immediately associate that with ischemia, and I'm going to start my check down process. Tall pointed T waves, hyperkalemia, or hyperacute changes of MI in its earliest stages. Okay, so 14.5, the abnormal T waves. And you see the normal T wave, the tall pointed T wave, the inverted T wave, and the flattened T wave. All right, QRS complex. See what the normal Q waves look like. See what the significant Q waves look like. So they're either going to be 0.04 seconds wide, or at least 1/3 the size of the R wave. Okay, flip back to what we were doing with in chapter 13. Okay, we was looking at the different sizes. All right, so normal versus significant SQ wave. The Q waves. Note the subtle differences. Okay, you see what the normal Q wave looks like. This is what you're used to seeing. Now look at the significant Q wave. Okay. All right, the R wave progression. Looking pericardial, the precordial leads. R wave starts out small, and V1 becomes progressively larger until V6 is tallest. Sometimes poor R wave progression is only endocardiographic evidence of an MI. Okay, so sometimes you may not see everything, but looking at that R wave, it lets you know that, hey, that there's something going on. We need to do some further investigation. Okay. All right. The progression of the transition zones, the leads in which the QRS becomes isoelectric should be V3 or V4. Okay, so we're gonna start looking at those leads when we're looking at the we're looking at these. All right, determine the heart's rotation. Counterclockwise rotation transitions between V1 and V2. Clockwise rotation transitions between V5 and V6. Okay, so this is what it looks like on the EKG. We see the normal transitions in V1 through V6. We see what they look like in the counterclockwise rotation. Okay, and then you also get to see what it looks like in the clockwise rotation. All right, and if you just look, you see what the normal and clockwise look the same, and the counterclockwise is these two in reverse. So you have the see how you have the how they are inverted here, and then you see the tall pointed waves here in the back. All right, the evolution of a STEMI. STEMIs occur over a period of time. EKG changes are its evolution. All right, again, going back to that original analogy, any changes in your direction, those are the changes that have the evolution that takes place. Okay, so here on this chart, I want you to note the changes. This is what you would look for when we're doing the check down process. Okay, so we see T wave inversions, cardiac tissue is ischemic. Look at the mark. We see marked ST elevation with upright T wave. That's an acute MI, starting with myocardial injury. Significant Q plus ST elevation, upright T. Some of the injured myocardial tissue has died. Significant Q plus less ST elevation marked by T inversion. The infarction is almost complete. Some injury and ischemia persists at the infarct edges. Significant Q plus T waves. The infarction is complete, though there is no more ischemic tissue. It has either recovered or died. The T wave inversion persists, and the significant Q wave only presents signifying permanent tissue damage. Okay, determining the age of an MI. MI's age must be determined by indicative changes present on the EKG. Acute ST elevation, less than 1 or 2 days old. Age indeterminate. Significant Q waves, baseline or almost back down to baseline ST segment. Inverted T waves, several days old, up to a year in some cases. All right, it's an old significant Q waves only. ST segment at baseline. T wave is upright, weeks to years old. Okay, again, these are all the things that you'll be seeing on the EKG, just to help you determine what the condition of the patient's heart is. Say it's your first time dealing with this patient, and you pick up their folder and you see these things on an EKG that may be in there, so you already know what you're dealing with. So you kind of have an idea of the method of approach you should take when dealing with them. Okay, walls of the left ventricle. Here we get into things covered in chapter 1 and chapter 3. Told you all, things are just explained more in detail. The things that we learned in the class are just learn more or explain more in detail. We're attempting to bring everything full circle. So if you will look back at page 9, all right, the infarction occur mostly in the left ventricle. Greatest oxygen demand, impacted more adversely by poor coronary artery flow. Okay, anterior walls is your front wall supplied by the left anterior descending coronary artery. Inferior wall is the bottom supplied by the right coronary artery. Okay. All right. We have the lateral walls, the left side supplied by the circumflux, posterior walls, the back wall supplied by the right coronary artery. Okay, so here the different walls of the ventricle. So your posterior, inferior, your lateral, your anterior. Okay, walls of the left ventricle. Um, let me, no, I can't go back. But thinking about, oh, and I skipped ahead again. All right, so thinking about what we just looked at on at 1410, I want you to look back to page 36 at 31, 35, 38, and table 33. Okay. So where are we at now? We're on 1410. So the leads looking, see what the leads looking at the anterior, inferior, and lateral walls of the left ventricle. All right. Again, I want you to look back at 333 on page 38. The posterior wall MI changes. So we're looking at, this is what we'll see in V1 and V2. If the MI is in the anterior, this is what we'll see in V1 and V2 if it's in the posterior. All right, walls of the lateral ventricle. The only way to diagnose a posterior MI is to look for changes opposite those that could be seen in an anterior MI. The easiest way to find posterior MIs is to turn the EKG upside down and look at V1 and V2 from the back of the EKG. All right. Myocardial infarction locations. The STEMI is diagnosed on the EKG by indicative changes in the leads of that area. Typical changes electrically opposite of the infarct area. MIs can extend across into other walls. They can extend across into other walls. And we're going to touch on that. A combination. MIs do not always involve every one of the usual leads. Okay. All right. So we on 14.1. Again, I want you to look back at tables 3.3 on page 38. Okay. See how everything lines up. Okay. All right, the infarction squares. Now that the leads have ST elevation, and note that which leads have ST elevation and a significant Q wave. Use the infarction squares to determine the types of infarction. Okay, so what your infarction squares look like. All right, an interior MI. Look at V1, V2, and V3. Okay, we see the ST elevation. We see the T wave. Okay, an inferior MI. We'll look at lead 2, 3, AVF. All right. Looking at the changes there, and that's how we know that this is an inferior. All right. So now we're on to the lateral. We'll look at leads 1, AVL, V5, and V6. All right. The posterior. We'll look at V2. All right. Why are we looking at V2 when we're on for the posterior? If you know, so you drop your answers in the comment section up under here. All right, an extensive anterior MI. Okay, so we're gonna look at V2 through V4, and then you can also see it in V6. As you can see that it's starting in the front and it's starting to move to the left. Okay, the anteroseptal MI. It's an acute, so we're looking. You can see that by looking at the ST elevation in V1 and V2. So the STEMI, the ST depression and T wave inversion. Okay. Um, Note that an STEMI can only be diagnosed in its acute phase. It's the only time you can catch an STEMI. Okay. So now we have the myocardial infarction algorithm. Here we are combining the infarction square that we just learned with the flow charts that got introduced to us in chapter 11. All right. Again, it's just reading the criteria just like how you would with asking your questions to determine the interpretation of a rhythm. You ask your questions, do the check down, and it'll help you determine, make the right diagnosis. So we 1412. This is the MI algorithm. This is just essentially what it'll look like on the chart. So if you walk through the questions from the infarction algorithm, you'll see how everything lines up here with the EKG. All right. Right ventricle infarction accompanies inferior MIs at times. So be mindful of that. Occurs when the blockage to the right coronary artery system is so extensive the damage extends to the right ventricle. And we just talked about this another just expounding on how something starting in one area and moving to another area. Like in the event that the wreck happened, somebody tried to avoid it, wasn't paying attention, and they wrecked they tried to avoid a wreck in one lane, tried to switch to another lane, and they caused another wreck. Okay. Okay, does not show up on a standard 12 lead EKG. All right. Again, this is why it was so hard for them to determine that Miranda was having a heart attack, because you can't see this stuff on a regular 12 lead EKG, and plus again because women don't exhibit the same signs as men. All right, right side EKGs must be done. Diagnosed by ST segment elevation in the right side EKG, focusing on leads V3 and 4R. All right, V3 through 4 on the right side. I apologize. I didn't mean to confuse you. Suspected when symptoms are more severe than an inferior MI alone should cause. Okay, so 14.3 shows us how the leads are placed on the right side. All right, want to refer back because we're a little sketchy on how things look or how they compare. Refer back to, you guessed it, page 38. All right. All right, the right ventricular infarction, right side of EKG leaves limb leads in normal place, moves the precordial leads to the right side of the chest, ST elevation, and leads V3 to V4. So inferior MIs will still be obvious. Okay. So this is just what a right side of EKG will look like with a right ventricular infarction. Okay. All right. Pericarditis, ST segment elevation, may extend, imply an inflammation of the pericardium. Pericardium and myocardium just beneath it are inflamed. Causes ST elevation, can mimic an MI, tends to be concave, is widespread throughout many leads, causes chest pain, crucial to differentiate from MI. Okay. So this is what pericarditis looks. You have the smiley face or the frowny face, depending on if it's concave or convex. All right. There's another example of what pericarditis looks like on an EKG. So early repolarization normal, variant, sometimes even seen in young people, especially young black men. Repolarization begins so early that the ST segment appears to start before the QRS is finished. Early repolarization results in mild ST elevation that does not evolve on serial EKGs. Look for fishhooks and precordial leads. No symptoms will be exhibited. Okay, this is what a fish hook looks like. This is what we're looking for here. If you ever seen a fish hook, you can Google it. You'll see how this kind of mimics what a fish hook looks like. Okay, this is what early repolarization will look like on the EKG. Note here we're looking at V3 through V6. Okay. Let's get over that. We'll come back to this later, guys. All right. Electrocardiographic complications of MI. Okay. So myocardium is damaged during the MI, usually for some degree of heart failure to occur. Heart compensates by pumping more often. Sinus tachycardia is common following an MI. Decreased diastolic filling time, not enough time for heart to fill with blood, can lead to cardiac shock. Okay, and it's just like your heart trying to do too much and it's getting burnt out. So a good way to think of that. Arrhythmias are common following MI. Ventricular fibrillation is often seen. Can be fatal. Myocardium is very irritatable during and after an MI. Anterior MI, Mobis 2 second degree, AV block, third degree AV block with wide QRS, bundle branch blocks, sinus tachycardia, ventricular dysrhythmia, VFib in the first hours after infarct, ARVR, right bundle branch blocks, left posterior hemiblock, inferior MI, bradycarditis, first degree AV block, winky block, ventricular dysrhythmia, VFib in the first hours after infarct, accelerated junctional rhythm, junctional bradycardia, AIVR, third degree AV block with narrow QRS. Okay, so again, this is just what they look like depending on the area of the heart. Anterior septum MI, same as anterior MI, along with increased risk of late VFib. Greater than this typically happens if the patient comes in after 48 hours of suffering a heart attack. Okay, treatment of MIs, all suspected MIs. Treatment is gonna be the same for all MIs. Okay, 12 lead EKG and blood work must be done. Labs troponin T and CPK. All right, so I am willing to offer 3 bonus points to the first person that messages me. It can be via text or on the messaging app on Edmodo with the correct tubes for these 2 tests. The first person, gotta be the first person. All right. So you have Mona, the morphine, oxygen, nitro, and aspirin. You only revert to Mona if there is no contradiction. Okay, patients will be started on oxygen by nasal cannula, nitroglycerin that dilates narrow coronary artery, the morphine for chest pain, treat and prevent heart failure, aspirins to chew to help decrease platelet irrigation. Treatment of STEMI and NSTEMIs differ. NSTEMIs are treated less aggressively early on. Antiplatelet or anticoagulant medications, beta blockers, all right, angiograms. Treatment of a STEMI is more emergent cardiac catheterization labs for reperfusion, a stent, um, from well, mouth dry, uh, thrombolytics, increased risk of blood. And I apologize, y'all. Hospital admissions if needed. Okay. All right, and so that is that. We're gonna stop it right there. We'll come back to this